You count stairs now, 13 to the garage, and by the fourth tread, the inside of the joint gives that hot, grinding catch. Your hand on the railing before you decide to reach, then the part nobody prepared you for. It aches while you lie still. Arthritis was supposed to hurt when you moved. No one said it would wake you at 2. I am an interventional pain physician, and this is what I want you to know. I practice interventional pain management in St. Louis at the Padda Institute Center for Interventional Pain Management. Here is the 15-minute version of your care. An x-ray and the words bone on bone. A steroid shot lasting 6 weeks, then 4, then 2. Gel shots. Then, too complicated for a replacement, come back in 3 months. A calendar, not a plan, and it fails hardest on people who cannot have the operation the system is organized around. Articular cartilage has no nerve supply. None. The tissue that looks worn on your film cannot generate pain. Where's the pain manufactured? In the synovium, inflamed and thickened. In the subchondral bone beneath the plate, densely innervated, remodeling under load, microfractured. In the capsule and periosteum. Knee arthritis is a whole joint disease. Radiographic severity tracks pain loosely. Nerve growth factor, upregulated in the arthritic knee, sensitizes peripheral afferents until ordinary load reads as injury. Sustain that and the dorsal horn amplifies it. Central sensitization, which is why the knee burns at 2 in the morning. Before a needle goes near a knee, the knee must be proven the source. The assembly line skips that. Hip osteoarthritis refers to the medial knee with a normal knee exam. Internal rotation reproduces it. L3 or L4 radiculopathy projects into the anterior thigh. Pes anserine bursitis is tender below the joint line, not inside. Insufficiency fracture and osteonecrosis are MRI diagnoses. A locked meniscus is surgical. Silencing the nerves that report it is a serious error. A hot swollen joint is septic until proven otherwise. Exam, weight-bearing films, labs, MRI, the target. The anterior capsule is supplied by small sensory branches, the genicular nerves. 3 are consistently addressed, superior medial and superior lateral, at the junction of the femoral shaft with each epicondyle and inferior medial, at the junction of the tibial shaft with the medial epicondyle. The inferior lateral is deliberately left alone. The common peroneal nerve runs too close, and a foot drop is not an acceptable price for a knee. They run with the genicular arteries. Needle position is earned under imaging, not estimated. The first procedure is not a treatment, it is a question. A diagnostic genicular nerve block puts a small volume of local anesthetic on those branches under imaging, then sends you out to use the knee and record what happens hour by hour. If those nerves carry your pain, it falls sharply and briefly. If it does not fall, either the pain is generated somewhere other than that pathway, or the anesthetic never reached the branch it was aimed at. Those are not the same finding, and the difference must be settled before anyone makes a lesion. A block cuts both ways. It can be falsely positive and falsely negative. The volume stays small. An equivocal result is repeated, not rationalized. It predicts who is likely to respond. It does not prove anything. The anesthetic can leave the leg weak. Arrange a ride. You do not drive. Ablation follows a clear block. Electrodes go to the same targets under fluoroscopy. Before any lesion, low-level current stimulates. Sensory, to confirm the tip is on the branch carrying your pain. Motor, to confirm it is not on anything that moves the leg. Only then is tissue heated. The axons undergo Wallerian degeneration and stop transmitting. No bone is cut, no ligament divided, the knee no less stable. But the lesion sits against periosteum and heat is delivered next to bone, which is why the rare bone complications I will name are real, not theoretical. Now the arithmetic. In Choi and colleagues' double-blind sham-controlled trial, published in Pain in 2011, 10 of 17 treated patients, 59%, reached at least 50% relief at 12 weeks. No sham patient did. Hold that number the way its size deserves. 38 randomized, 17 analyzed. 12 weeks is where that trial ended. A 2026 meta-analysis by Barreto and colleagues in pain medicine pooled 8 sham-controlled trials, 627 adults ineligible for joint replacement. Treated groups averaged 1.65 points better on a 0 to 10 pain scale than sham, and about 11 points better on WOMAC function. Averages of a difference, not a promise to you. Heterogeneity so high the trials barely agree, and almost no long-term data. Note which technique won on subgroup analysis. Conventional monopolar ablation, the off-label one, not the cooled system with the clearance. Regulatory status and evidence point in different directions. Know that before anyone calls the cleared device proven, 3 to 12 months of relief is clinical convention, not a trial result. Nerves regenerate, repeat treatment is ordinary, 4 in 10 selected patients never reach 50% relief, ablation does not slow the arthritis, and long-term denervation of a weight-bearing joint is unsettled. The material risks: bleeding or injury to a genicular artery, infection, a numb patch of skin over the knee, painful dysesthesia or neuroma, thermal and grounding pad burns, a pain flare lasting days, radiation from fluoroscopy, and rare reports of osteonecrosis or periarticular fracture near the treated site. Cooled radiofrequency systems are FDA cleared for knee osteoarthritis pain. Conventional monopolar and bipolar radiofrequency of these nerves and chemical neurolysis with phenol or alcohol are off-label. Ask which device and which technique is planned for you. Now, viscosupplementation, gel shots, hyaluronic acid injected to lubricate the joint. In 2022, Pereira and colleagues pooled 15 large placebo-controlled trials in BMJ, more than 6,000 patients. Pain reduction against placebo was about 2 millimeters on a 100 millimeter scale, far below any clinically important threshold. Serious adverse events were more common, relative risk 1.49. Its own harms: inflammatory or pseudoseptic flare, joint infection. American Academy of Orthopedic Surgeons, 2021. American College of Rheumatology, 2019. Both advise against routine use. Saying this on camera costs practices revenue, including mine. What carries weight in an arthritic knee, quadriceps and hip abductor strengthening because a weak quadriceps lets the joint take load the muscle should have taken, and weight management because body mass multiplies across that joint with every step. Nutritional strategy: omega-3 derived pro-resolving mediators, red and near-infrared light. I use those around these procedures, but for knee osteoarthritis, the mechanisms are largely preclinical and the trials small, adjunctive and emerging, not standard of care. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Someone in their late 60s, arthritis in both knees, worse on the right, cardiac history and body weight that made a surgeon unwilling to operate. 2 steroid injections, each lasting less than the one before. Gel injections, no change. Hip and lumbar exams normal, no effusion, no fever. Diagnostic block, 7 to 2 for about 4 hours, with the expected leg weakness. Someone else drove home. Then cooled radiofrequency ablation. The first 10 days were worse. A pain flare, ice, a call on day 6 asking whether this had been a mistake. Relief consolidated over 3 weeks, not zero pain. Roughly half, enough to reclaim the stairs, sleep on that side, load the quadriceps. The numb patch above the kneecap is permanent. Somewhere around 6 months, the pain began coming back as the nerves regrew, and the ablation was repeated after a second conversation about the same modest numbers. I chose 6 months for this composite deliberately. Some people get longer, some get considerably less. The sham-controlled evidence stops at 12 to 24 weeks, so no one, including me, can tell you in advance which you will be. That is the shape of a genuinely good result: partial, time-limited, repeatable. This is not for you if you have an active joint or skin infection, a locked meniscus, a bleeding risk, or anticoagulation that cannot safely be held, or untreated inflammatory arthritis. If your knee pain has outlasted the injections and replacement is off the table, the next question is not which shot, it is where the pain begins. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Bring your films and injection dates. The longer explanation lives at painmd.tv. Make them prove where the pain comes from before you let anyone treat it. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.